notice.nv.gov. Please refer to the engaged feedback checklist from our first meeting. And we'd like to remind all BAC members that this is a safe and respectful space for everyone. Okay, moving to agenda item number 2, disclosure of any conflicts of interest. Please disclose any conflicts of interest that you have at this time. Move on to agenda item number 3, roll call. Administrator Ann Jenses. Bill Sims.
Here.
Azraela Gravel.
Here.
Jessica Funderburg.
Here.
Lolly Queen.
Present.
Brooke Blanco. Did you see Brooke on the?
She wasn't here last time either.
No?
I don't believe so. We'll keep an eye on the.
Okay, thank you. And Grace Larkins, I'm present. Jonathan, have you met quorum?
Yes, we have a quorum.
Thank you.
Going on to agenda number 4, this is Azraela Gravel, Vice Chair speaking. If you would like to make a public comment, please raise your hand or type public comment in the chat or the last 4 digits of your phone number, and your name will be called on to begin. Oh. Please state your first name and last name at the beginning for recording purposes. You will have 3 minutes to speak.
I'll say public comment in the chat.
Okay, moving on to agenda 5 and 6. It will be on the discussion of November meetings and vote on meeting minutes. Meeting minutes, we were set to council members on December 11th, 2025 via email for review. Is there any discussion on the minutes at this time? Chair will call on members individually to provide feedback. Once feedback is provided and consulted with DAG, Chair may then call for a motion to approve. Calling for a motion to approve. Okay.
A second.
The motion has been approved.
Do you want to call?
Yeah, I'll do roll call.
Okay. We'll have to have the members vote. Okay.
Bill Sims.
Do you
Here.
approve this?
Oh, yes, I do. Yes.
Thank you, Bill. Azraela.
I approve this motion.
Jessica.
Approve.
Ilani.
Yes.
And then Grace.
Yes.
Okay, we called for a motion to approve and it has been approved.
Thank you. Agenda item number 7, very excited to introduce Ann Jensen for our administrator's report.
Thanks, Grace. Good morning, all. For those I haven't met, I'm Ann Jensen. I'm the Medicaid Director here in Nevada. Really excited to be here. This is always a highlight of my month to get to spend the day together with our BAC and our MAC meeting. So thank you all for taking the time to be here and wading through all of our procedure and all these meetings. You're doing a wonderful job, and I want to thank our chair and vice chair for all your work to really shape this time together. So as I've shared in each of our past meetings, I'll include in my administrator's report updates on 3 top priorities that we have across our Medicaid division right now. These I imagine may feel familiar, and as you guys took a look at the meeting minutes, will be familiar to what we had last quarter and what's intentional. the important projects we're working on take a lot of time to implement and to work on. And so you'll see similar things come up. What I will share each quarter in the meeting though is what we're currently focused on within that overall project. So you get a better sense of where our priorities are and what our immediate kind of short-term steps. So firstly, I'll share talk through. So first will be related to our managed care implementation of our new contracts. Number 2 will be about legislative implementation, new state and federal rules. Number 3 will be about kids pay. So I'll go through each of those individually, and then we'll be happy to take any questions from the members at the time. So as I mentioned, number 1 is our new managed care contracts. I think what's really important here, and you'll hear me say it intentionally this way, yes, we expanded managed care to our rural and frontier communities. That was a key step in the process of our new contracts. But we also made a number of other really significant changes. And so I want to kind of group those all under one. So again, for quick context, managed care is one way that states can use to provide Medicaid coverage. And that means that instead of the state Medicaid agency being the name on your Medicaid card, it's the name of a private health plan that has contracts with the state to help the adjudicator run the Medicaid program. So Nevada has had managed care in our state for a long time, but historically it's been focused in our urban Washoe and Clark counties, with about 70% of our Medicaid patients receiving health coverage through a managed care organization. So as we prepared for our new contract cycle, we have contracts with managed care organizations that last about 5 years. So every 5 years, we go through a process to create a new contract that describes the expectations the state has for our managed care partners. And we go through a really lengthy, about 1.5 year procurement process. And what that means is we put our contracts out in the world and say, who is interested in bidding on this? We review their application based on a number of different factors. And then we select those bidders, award the contract, and move towards implementation. So this whole process started honestly well before I even joined the state in 2024. It's a really long process, but really proud to see it come to fruition with those new 5-year contracts starting on January 1st, 2026. So some of those changes that were made, I think the obvious one is we expanded where managed care is available. So now managed care contracts are extend across the entirety of our state of Nevada, meaning that we have 2 MCOs that offer health plans in every county in our state. We have 4 health plans in Washoe County, and we have 5 health plans in Clark County. So the choices that members have look different depending where they live, but managed care is the primary delivery system for all of our patients, with the exception of folks with disabilities that are in our waiver programs, foster care community, and tribal members that voluntarily opt out of managed care. So now we're right about 90 to 92% of Medicaid patients in our state receive their health coverage through a managed care provider. So about 70,000 new people, 70,000 Medicaid members newly are part of a managed care organization that historically received fee-for-service. So that's one big change. I want to commend and appreciate our partners, CareSource and Silver Summit, that are managed care organizations that work in the rural and frontier communities. They've been hard at work on this rollout since the contracts were awarded. We're really proud of this as a state of how this contract implementation has gone. It is a huge change and it has been successful. There's of course bumps in the road and things that we've all worked to address really quickly, but all the feedback we've gotten to date has been positive, and that folks have been able to work through trying to So I know we'll be discussing the statewide expansion of managed care later in the agenda, so I'll save more detail for that. I just want to acknowledge that's one of multiple things we changed in our new. Another big change, we changed the way that providers get paid. And what that means is we included a provision in our new contract that set the Medicaid fee-for-service payment rate to providers as the lowest or the minimum amount that managed care organizations can use when contracting with those providers. This gets wonky, Medicaid payments, so we don't need to go into full details, but I think what's really important here is we have essentially set a floor to say that providers can't get paid less than what the state pays for these services to ensure that there's clear continuity across all of our payers. So that's one key change. The other key change is we've moved to a single prescription drug list. And what that means is rather than having 6 different lists of which drugs are covered or not covered, we have a singular list that all 5 managed care organizations use and the state fee-for-service program uses that reflects the generic and brand name drugs that are not only covered but preferred and kind of used in what priority order within the state. Our pharmacy world is incredibly complicated. That may be a valuable topic to cover in future meetings if that's of interest to the members. But I think what's important here is the goal is to simplify the way that prescription drugs are covered in our state. So that way when folks move between MCOs or they move across the state, they don't have to change their prescriptions to do so. It helps patients be able to have more consistent care with their pharmacy benefit. It also helps our providers. They don't have to look up 6 different lists to figure out which drug they can prescribe in what order. We all have the same rules now and how that happens. So for all of these changes, we recognize this is a big change to our program and policy. So what we've put in place is a 6-month window called a care continuity window, but it essentially says any service that was authorized by your doctor or your health plan or the state before January 1st will be honored for the first 6 months of this year to allow the health plans, if it's a new plan, time to work with you and with your doctors to ensure that whatever coverage changes need to happen, everyone is on the same page with and feels good about it. So we're working really closely with each of our health plans and all of our district offices. I do want to shout out our team at our district offices, which works to kind of member support directly. They fielded 3 times the normal volume of calls in the month of January, because a lot of people had questions on, who is the new name on my card, or how do I find, does my doctor accept this, work with this health plan, right? They've done extraordinary work to answer everyone's questions and ensure that they get access to the care they need. So I want to thank them, and I look forward to feedback from the group here in our later discussion item on any opportunities that you all see or have for us to consider to continue to make this transition a really smooth and successful. So that's number 1 on our managed care contracts. Number 2 is all things legislative updates. So I know I shared this back in Vegas at our last meeting. Medicaid, as we talked about in our very first call, is a really unique health coverage program because we follow both federal and state laws in everything we do. It's a federal and state partnership. The Social Security Act and all regulatory guidance and laws on the federal side dictate our program, as do everything that is passed within the Nevada legislature as well. So I'm really excited for my colleague Casey Ingris to provide some updates on the state legislative implementation. I won't steal her thunder, but we're doing really well in terms of making progress towards implementing all 37 bills that were passed in our last legislative session. We never can rest on our laurels though, or focus too much on the past, because we're also now preparing for next legislative session. And so that will begin in February of 2027. And we're beginning the process to develop our agency budget request, which is part of the governor's recommended budget. That is an over a year long process to prepare for the governor's state of the state in January, and that budget will be released then. So ton of work on our end to figure out where are we at after our last session, where do we have opportunity. In Nevada, we build our budgets on a 2-year cycle, which for anyone that manages their own budget, does their own budgeting, like I do, I can barely budget even a couple months ahead, and here we are trying to project into 2029. So really a process we do with a lot of care, and so all the leaders on my team are working hard to ensure that we're preparing and anticipating what things we may need come 2029 so we can budget and request for things. The other component, though, of our legislative work is, of course, the federal changes. So we talked a lot about what is called the One Big Beautiful Bill Act. I call it HR1 because I always get the number of B's wrong. HR1 is a federal law that was passed in July of last year that impacts a number of different things, including our Medicaid program. There's 2 main areas that we've talked about where these changes impact. One is on the money side, that's the fiscal side. There's changes to the way that our hospital tax program can be designed. What really matters there is hospitals will see less money coming to them through the supplemental program. And our funding for some children's behavioral health initiatives will still exist, but we'll get less money in that account than we had originally anticipated. So what we're doing as part of that budget planning process is ensuring that we have other means to cover all of the services and planned work that we're doing in children's care costs, because that remains a top priority. I feel confident in our ability to do that. So I'm really grateful that in Nevada, we have fewer fiscal impacts than maybe some other states are feeling right now. And most of that would hit actually in the budget cycle after this next one in 2030 and beyond. But we're definitely planning to make sure that we're prepared for those changes and absorb them as needed. The other bucket that's really important within HR1 is changes to the way that people become eligible for Medicaid. So I know we talked about this last quarter. There are changes to the eligibility process, but they're very specific to a portion of our Medicaid population. And that portion is adults without children that have relatively higher incomes that were part of what we call the expansion population. So they're relatively newer to our Medicaid program. Relative meaning over a decade, right? This is a long process. There's about 250,000 people on our program right now that fall into that bucket out of the total 700,000. So it's about a third of our population falls into this group. And so these changes include currently, as you all have experienced, every year you're expected to go through the process to provide information to show that you're still eligible for Medicaid. For this population starting next year, that's going to go to every 6 months. So it's a little bit more frequent. And when you go through that redetermination process, there's now going to be requirements that you demonstrate what's called community engagement. And that can include work, volunteering, school. There are exceptions to asking those requirements, though, based on medical condition, based on status as a tribal member, based on status as a caregiver for another family member. So there's a lot of complexity to who this applies to and how do you become compliant. And so what I want to just call out here, we're going to have our first policy workshop on our work requirements efforts in March. It will be, I believe, on March 21st, but I'll triple check that date and we'll make sure that's shared out with our back group. Will of course be posted to our website. And in that public workshop, we'll share kind of our initial thinking on some of the policy design decisions we're allowed to make as a state. And get feedback from our community on how we can do this in a way that best aligns with our goals here in Nevada. I'll note our federal partners are trying to understand the federal law just as much as we are. So we rely on their guidance on how we become compliant with the federal law. The majority of their guidance is going to come out in June of this year. And the hard part is this hits in January, meaning we want to begin notifying people that they have to provide more information late summer, early fall. And so we're already programming our systems and trying to develop and prepare for this before we have that final guidance from the feds. So it's kind of a dance. It's always, we're trying to build and make policy decisions with enough leeway that we can change them if we get more information from the feds that we need to look or do something differently. But as of right now, I'm feeling confident in our ability to meet the federal deadline of January 1st, 2027. That will do it in accordance with requirements and also in accordance with goals. So in our next back meeting, I'd love to actually spend some time, and if committee members are interested, going through a lot of those policy decisions and especially getting feedback on some of our communications material about this. I think this is, in my mind, one of the most crucial things we can communicate about in our Medicaid program. We have a lot of good practice in using text messages, email, social media, from what was called the unwinding process, where we needed folks to redetermine their Medicaid eligibility. That was a couple years ago. But we want to do right and be as creative and thoughtful as possible in how we prepare for these changes this year. So that will be a huge focus for us every quarter moving forward, but wanted to kind of reach you guys into where we're at in that process. So that was number 2, legislative implementation. And then the last one is children's behavioral health. So as I mentioned in the past, what we're doing here is developing a new health plan that's specially designed for kids in foster care and kids with complex behavioral needs. We are currently awaiting bidders' responses for our health plan. Since we last met, we made a couple program changes to what this looks like. The biggest of which is actually taking kind of geographically scaled approach to this health plan, kind of like what we did on the Medicaid Managed Care project. So we're going to start for the first year and a half for this health plan to first only be available in Washoe and Clark counties. And then we're going to expand that to every county in our state. Once we're really able to test that model, make sure it works well, we're going to need to in partnership with our plan that will be whoever is selected to run this plan. That doesn't mean we're not going to do work in our rural communities though, and with our rural families and providers in the meantime. We can't just sit and wait and magically hope that providers will pop up in our rural communities. That takes really thoughtful and intentional investment. So we're also preparing a request to the legislature in April for additional resources to help us design a model that really helps serve our rural community differently during that interim time period. It will be a lot of state work to provide enhanced care coordination and better support for kids and families across our rural communities. So a lot more to come on that front, but wanted to give you guys the update. So I'll pause. I know that's a lot of just me talking at you guys, but I hope helpful way to get a snapshot on our priorities. Happy to take any questions or feedback on this piece. I'll just note that state legislative updates will cover in agenda item 8 and statewide managed care agenda item 9. So I will be here for those discussions and happy to answer questions on those topics, maybe as part of the broader update. But any other questions?
Grace Larkins for the record. Thank you so much, Director Jensen, for those updates. I do have a question. Or the single payer prescription list. What if a provider feels that a prescription that's outside of that list is the most appropriate? Is there a out of network rate option or an ability to appeal that?
Yes, there's an ability to appeal as there is for any benefit within our Medicaid program. If a member is with a managed care plan, that appeal first goes to the managed care plan. If you're part of the service, that appeal goes to us at the state level. But either way, the state can review us and the appeals. The goal, what we always do, is to take a look at the medical necessities. So that is the kind of requirement that we need to meet for it to be able to use state funds to be able to cover this. There are conditional approvals for exceptions if clinically necessary, but for the most part, that list should be pretty comprehensive, and we're not saying too many concerns or this there. This is essentially the list is a combination of input from all the health plans and from our state team, and so we're proud that that really reflects what we believe is a really comprehensive set of pharmacy coverage based on what we have federal approval. Does that help answer your question?
Absolutely. Yeah, thanks so much.
Yeah.
Azraella speaking, Vice Chair. I did have a question. You had mentioned that your delivery systems were updated. Providers had concerns about prior authorization in our last conversation, and I wanted to know if you had an update for that.
Yeah, great question. So I didn't actually, Casey will likely cover some prior authorization updates in her legislative update. That's a big state bill that impacts that, but we'll just note on our end, there is a lot of work to streamline the way prior authorizations happen across all of our payers. We all, as a kind of state and MCO partners, that makes it better for everyone if we have a consistent process. So that continues to be an ongoing effort to refine. I think at this point, our kind of basic kind of first questions in the prior authorization requests are consistent across all of the payers. But there's a lot of state and federal laws that dictate the response to prior authorization. And so that's what Casey can talk about. But that's another big change effective January this year. Everyone has a shorter, payers have a shorter turnaround time to get back to providers to ensure that FDA decisions are made as quickly and efficiently as possible. So a lot of work on that end, but I welcome feedback from you all, and then we're happy to providers if there's further opportunity. I think prior authorization is a complex process, and we're trying to always balance making the request as simple as possible, but also make sure we get all the information that we need to be able to make a decision that aligns with the patient's clinical need and best interest there.
And to follow up, I did see that you said 2030, the budget cycle will see the fiscal effects of no supplemental programs for hospital tax and the money thereof. In our last meeting, you noted that on January 1st, 2024, the federal government is waiving or refusal to serve the vulnerable populations and they might be at stake. Have you guys had any updates regarding that? Because you mentioned in June that there's going to be federal changes.
Yeah. Help me understand, can you remind me what January 1st, 2024 you're mentioning?
I think we were talking about the legislation. The last thing we were talking about was the medical respite services having transportation concerns, and that you would address it in your weekly meeting.
Okay. So honestly, I'm just trying to remember the context for the initial conversation, but I appreciate you raising on the federal side. So I think when the federal bill passed, we were all trying to analyze the impacts quickly. And so thankfully, we now know a little bit more.
Okay.
I actually had to step out for a call a little bit later this morning for a call with CMS about our hospital tax guidance, because we're all trying to understand how do we interpret the law and make our program changes accordingly. So importantly, that hospital tax program is the way that the state gets funding for children's behavioral health and for payments that we then pay to hospitals as kind of supplemental payments. That program will still exist moving forward. It's just the amount of money that we can collect and pay out is lower than we had initially planned for it to be year over year. So given that we don't think the impacts to patients we are trying to in every way make those as minimal as possible. And at this point, we don't have any concrete kind of areas we can point to what's going to be significant impact. I think what we're continuing to do is working with our hospitals to figure out, as the amount of money we expected to get gets a little bit smaller, what changes does that mean and how can we that process? But on the kids' behavioral health side, we're doing everything we can to use other types of funding to pay for this program, so there's no impact.
Is it going to impact our rural hospitals?
Every private hospital was on this program, so our rural hospitals may be impacted by it. We're seeing most of the impact actually from larger urban hospitals.
Oh, okay.
But there is impact across. And so in the federal legislation, there's something called the Rural Health Transformation Fund, which is a new pot of money the federal government established and to kind of support our rural communities there if that's a topic of interest. Our team, we have an excellent team leading that work, including Melinda here. Nevada was awarded some significant funds through that program, and so happy to provide updates. That is, so that's intended to really support our rural providers as they kind of navigate these changes. But I think hospitals across the state will see some impacts coming into 29, 2030.
Thank you.
Yeah, absolutely, good question.
Do we have any questions from our members online?
Greg Larkins for the record. I do have one more question. Director Jensen, the prior authorization process that we're talking about and some of those changes, is that piece going to be part of Casey Anger's legislative update?
Yes.
So I might hold off on some questions I haven't.
Okay, yeah,
Okay.
hold those for the pizza section. I believe you'll be touching on AB 463, which is the bill that changed our PA process in the state of Nevada. Happy though, I'm also close to that process and happy to answer any questions as part of that agenda item too. But yes, definitely a key topic of interest and happy to answer questions.
So I do have a question related to that. Just in the processing for fee-for-service Medicaid, I believe it's Gainwell that processes the prior authorization and claims. I know that's across durable medical equipment and that's the one I'm the most familiar with. But I'm also curious, is that across all fee-for-service claims that are put through all Gainwell? And then does that also apply to provider re-eligibility or as they apply for contracts? Is that also Gainwell? I just heard that yesterday and that sort of surprised me. That's also Gainwell.
Yeah, so great question. So Every Medicaid agency in the US has to have what's called a Medicaid Management Information System, or an MMIS. In our state right now, the contract for MMIS is through GAMA. So they do a number of different work on behalf of the state of Nevada. That currently they have the contract to process claims, as well as support us through the provider enrollment portion of our program. We have a separate vendor that helps us on the credentialing side. So this is wonky, but really important. Any provider that gets paid by Medicaid has to first enroll with the Medicaid program. That's run by the state. And we decide based on whether folks meet the criteria that we have in our state law, federal law, and then our policy, if someone can be a Medicaid provider. Once you're enrolled as a Medicaid provider, then you can choose who you want to participate with in terms of various health plans, right? So we have 5 MCOs, like I mentioned. Providers can choose to contract with all 5 of them, just one of them, any combination, or just be a provider for fee-for-service. That process is called credentialing. So you also have to meet separate requirements to be able to be part of a provider network. And so we recognize that's a pretty administrative process, and for both our providers and for us and for our managed care partners. So we have a vendor that helps us through what's called a centralized credentialing process, meaning a provider submits one application that says, I want to be credentialed for these plans in the state of Nevada. And then that vendor works with each of our partners to go through that credentialing process, and they get an approval, yes or no, from each of those MCO columns. So that's a relatively new change. It happened at the beginning of last year, but that is a separate vendor than GAMA. Otherwise, the enrollment process is all connected to GAMA as part of their broader support of our state. Is that helpful?
Yes, thank you. And that, do you have the name of that vendor? Is that
Yeah.
for like credentialing?
Yeah, let me get back to you on their kind of national name. There's like state specific names, but I think it may be helpful. So I'll take involved with you on that. Yeah, but Verisys is the name of our, like what it is in Nevada.
Okay.
Yeah.
Great. So with the creation of the Nevada Health Authority and the continuity among the different agencies, I thought there was an intention to have the providers consistent even across the MCOs and fee for service. So, and maybe I misinterpreted that, or maybe things have shifted. Is that something that for the long term is still a goal?
Do you mean consistent across the MCOs, that the same providers are in every single MCO?
Yes, it was my impression that there was going to eventually be a goal of even having like the PEB, the public employee benefits, as well as Silver State, and then all of the Medicaid, aspects, including the MCOs and fee for service with the same. Is that?
Yeah, so your understanding is correct in that the goal of the health authority long-term, and we're working through kind of modeling on how to do this, would be to have providers participate in each of our programs. So Medicaid, the public employee benefits program, the exchange, including some options, our public option plans within the exchange. Importantly, though, I just want to be really clear. Participating in the Medicaid program doesn't mean that you participate with every single MCO. So as part of the kind of core tenets of managed care and federal regulation, managed care organizations have the right to design their own provider network that meets the state's requirements. So we set the benchmark to say you have to have a provider network that meets these requirements, and we're going to evaluate you using an external evaluation agency to make sure that you're doing. That doesn't mean, though, that every MCO has identical networks. And honestly, most MCOs have broader, they have more providers in certain areas than sometimes our fee-for-service. So the provider networks will look slightly different across the programs, and that is because of the way our federal program is designed. But what we're really looking to do is to say, if you come in the Medicaid enrollment front door, we want to make sure that those providers are also able to participate in PEB in the exchange of others. So the first step of that, as part of state law regarding our public option plans, our battle-born state plans, these are essentially cheaper health plans on our commercial market. there is a law in place that will, the provisions are waived for this year, but will go into effect next year that says, if you are a Medicaid enrolled provider, you also have to be contracted to be part of that public option network. So that's kind of one example of what that looks like, to say, if you're in this program, you also need to be in this program. And so those types of models are what we're exploring in the health authority. But we, as a state, don't have the authority to be able to say, hey, provider, if you're enrolled with us, you have to participate with all 5 plans. That's a decision, a contracting decision between the health plan providers. Does that help?
Yes,
It's tricky, so I want to make sure that's.
yes, that makes sense. I appreciate the clarification.
Yeah, yeah.
I have a question.
Please.
Azraella speaking, Vice Chair. I realize that we don't have a Medicaid recipient on our member list right now for our group. So I wanted to just touch base as a former Medicaid recipient. And I know that you mentioned DWSS. They have extremely long wait times over the phone, and the automated voice messaging system is really, really long, and it hasn't been updated since COVID. And so now that we're out of the COVID era, I think we need to update that messaging system. And I'm not sure what Medicaid can do to help assist DWSS with those long wait times. But recently when I had to call for Medicaid, I didn't even get through even after 45 minutes waiting. And it didn't matter what time of the day it was, if it was in the morning, afternoon, or towards the end of the workday. So if you can just consider this as an item, I really appreciate it.
Yeah, thank you. I appreciate that. I'm sorry to hear that. I'll wait time. I know I'm being probably frustrating, and that is feedback we've heard of others that I know is very familiar with to our team over at Division of Supported Services. They got a new name as part of the reorganization as well. So they're now called DSS.
DSS?
Yes,
Okay.
yes, so many acronyms, right? The Division of Supported Services. So yes, we will absolutely take that back, especially on the automated phone line
Yeah.
script. I actually think that, if I recall correctly, that's something that they're actually working to update now, but I'll get an update. I'll make it to you. And we'll be sure to find ways there may be opportunity for this group even to weigh in on what that can look like. But we appreciate there's not enough staff to be able to answer all the questions, and they are constrained there. So one thing that we're doing on Print is actually a huge project I'm very excited about, and we'll share more on. We're building a new online system where folks can go online and in real time put in your information and figure out if you are eligible to enroll in Medicaid. That is really to make it a faster process. It'll run through our exchange website, which is already set up for folks to shop and compare health plans. So we'll be adding Medicaid as a part of that overall experience. And the goal is to allow folks to see all their coverage options, make the choice that works best for them, depending on what they're eligible for, and try to limit how many times folks have to go via phone or in person to our DSS offices to really allow their time to be focused on more complex cases or situations where folks need to submit more extensive paperwork, like our waiver programs. So I work very closely with our colleagues at DSS, and they're trying to always find ways to be more efficient, but we recognize we're not where we need to be right now, and that's incredibly frustrating. Jessica, I'm seeing your comment there too. So thank you for letting me know that. I will give this feedback to our team this afternoon so we can see about updating that phone tree line and identifying any other ways we can try to make that process faster or more accessible before we have the online system ready to go.
Because we have to, at the moment, call DSS to even contact Medicaid or to find out if we're eligible. And so that's incredibly frustrating. So thank you for looking at that.
Yeah, absolutely.
Grace Larkins for the record. I just wanted to point out staff that we have a agenda item. That would be a good agenda item at our next meeting to look at that. The DSS eligibility piece. I also have had comments through several family members who have gone through many hours of holds and confusion on that. So it's great to hear that there's awareness and a lot of already movement happening on that. So that's encouraging. But yeah, it'd be great to follow that up. Thank you.
Do we have any other additional questions and comments from our members online? to our chair and vice chair.
Okay, I guess we'll turn over to agenda item 8, legislative updates, but I think Director Jensen did go over the legislative updates.
The presentation.
Oh, okay, sorry. So the presentation so I will introduce Kimberly Smalley, Social Services Chief with the Division of Nevada Medicaid, to provide legislative updates.
Great,
Really?
I am. Thank you. Good morning. I am filling in for Casey Ingris, who's unfortunately unable to join us today. I'm going to walk through several of our Medicaid-related state bills and give a quick snapshot of where each bill stands. I heard that there may be questions on some of the legislation. For some of the more in-depth answers that may be needed specifically from Casey on the implementation of certain bills, I would be happy to take those back to her to get some more detailed answers for you if we are unable to answer those questions today or have a subject matter expert on the call. So next slide, please. Thank you. The first bill we are going over is Assembly Bill 36. This bill requires Medicaid providers to submit a request for a hearing within 90 calendar days of inaction, unless they can show there were special circumstances that prevented it. This timeline currently exists in Medicaid policy, but it's now formally part of Nevada state law. Assembly Bill 36 was effective January 1st, 2026, and Nevada Medicaid is currently drafting policy that will define what qualifies as extenuating circumstances. This policy change will be adopted in an upcoming Nevada Medicaid public hearing. Next slide, please. Assembly Bill 42 shortens the time frame for Nevada Medicaid to provide notice of adopting, amending, or repealing a regulation or policy from 30 business days down to 3 business days if the change expands services or is required to comply with federal or state law. It also changes, it also allows changes to be applied retroactively if it is required to comply with federal or state law, and the notice clearly states it will be applied retroactively. AB 42 was effective May 28th, 2025, and has been fully implemented. Next slide, please. Assembly Bill 315. This bill requires that all providers submitting an application to participate as a Medicaid provider must have notarization or have their identity verified through an electronic identity verification system used or approved by Nevada Health Authority. AB 315 was effective July 1st, 2025, and has been fully implemented at this time. Next slide, please. Assembly Bill 556 renames the Medical Care Advisory Committee to the Medicaid Advisory Committee, or MAC, and updates the MAC membership structure, compensation rules, and adds access to services as an area of focus. This bill also creates the Beneficiary Advisory Council, or BAC, which will advise the MAC on development of policy concerning Medicaid, with a focus on the experience of Medicaid beneficiaries in relation to Medicaid quality, access, and equity. AB 556 was effective January 1st, 2026, and has been fully implemented. Senate Bill 9. SB 9 updates Nevada Medicaid's third-party liability rules to align with federal requirements. When Medicaid beneficiaries have additional health care coverage, third-party liability rules govern the legal obligation of third-party payers. Updates are being proposed to reflect revisions to Section 202 of the Federal Consolidated Appropriations Act of 2022, which changed two requirements to include the pursuit of recoveries associated with commercial insurance or CI if they are the primary payer, and includes the requirement for any insurance carrier or third-party payer to respond to a state inquiry associated with recoveries within 60 days. SB 9 was effective July 1st, 2025. Nevada Medicaid is in the process of making changes to the Medicaid Services Manual, Chapter 100, and drafting a state plan amendment for federal approval. Thank you. Senate Bill 54. This bill directs Medicaid, when federal funding is available, to cover medical respite services for individuals experiencing homelessness. This includes acute and post-acute medical care and other support services. SB 54 is effective July 1st, 2027. Nevada Medicaid is working with a vendor to develop an application for an 1115 demonstration waiver amendment that must be approved by the federal government. This application will be made available to the public for a formal comment period once it has been drafted. Senate Bill 138, SB 138 is requiring hospitals to provide birthing services to enroll as qualified provider to decide if a pregnant individual can receive Medicaid. These hospitals and their partners must give people certain Medicaid notices. Parents and legal guardians of babies in the neonatal intensive care unit or the NICU must be given specific rights to help care for their newborns. SB 138 has an effective date of January 1st, 2026. Nevada Medicaid submitted a state plan amendment that is pending approval by the federal government now. Senate Bill 165 requires that Nevada Medicaid cover behavioral health promotion and prevention services provided by a behavioral health and wellness practitioner. The effective date for this bill is January 1st, 2026. Medicaid already covers the services of behavioral health promotion and prevention through prevention and intervention strategies like screening and rehabilitative services. The Board of Psychology Examiners has scheduled a public workshop for March 6, 2026, where they will review the certification requirements for this new type of healthcare professional. Once the certification for BHWPs is created and curriculum is delivered, Medicaid would expect more providers enrolled as qualified mental health associates with the certification. Senate Bill 353 requires Nevada Medicaid Agency to set up a new billing category and daily reimbursement rates for university-run behavioral health training clinics that train future behavioral health professionals. SB 353 has an effective date of October 1st, 2025. And Nevada Medicaid submitted a state plan amendment that is pending approval by the federal government at this time. And that is the last of the bills. Does anyone have, and we have links that may be used to for more additional information on Nevada Medicaid's implementation of various bills and initiatives, as well as our manuals, sections, SPAs, are all in all of our public meetings. Does anyone have any questions on any of these bills?
Grace Larkins for the record. I do have a question related to AB 315. This is the bill you discussed that is related to the provider who is seeking a contract. the enhanced verification through a notary or through electronic identity verification system. So my question, I actually was just recently speaking to a provider who has been contracted with Medicaid for decades, and they were prompted to apply and get that rolling earlier than they expected. They were expecting it would be another 2 years, but in that paperwork, I believe this is where this might have been triggered. They're at a standstill because the director, as part of it, was required to upload a photo of her driver's license as well as a video of herself. And she isn't comfortable with that because they were unable to confirm that it was secure. And she herself has gone through an identity theft in the past. And especially now, I think with AI and these deep fakes, they call them, and this and that. So I can understand the hesitancy of what that requirement of having not only within everything being submitted, having a social security number and having everything else, but also then having the driver's license as well as an actual video of them speaking. So is that part of this 315 safeguard that?
Yeah, I'm happy to take this one, if it's helpful, because I know this predates some of Kim's work with this bill. So yeah, we appreciate you raising that example. For context, this is part of a broader national standard process to ensure the integrity of all of our provider enrollment work. And so we as state are really cognizant of information security, especially after the cybersecurity incident we all went through last fall. So I can assure you this is absolutely a secure process. And this information is immediately deleted after the identity is verified. So if your colleague or connection wants to, if you want to pass along my information and have them reach out to me, I'm happy to provide more documentation. I totally appreciate the identity concerns and want to make sure people have the full information that they need to make a decision. But the kind of intention behind this is to ensure that anyone who enrolls in Nevada Medicaid is who they say they are. We unfortunately have numerous situations in which folks enroll with their name or information, which is identity theft of a different kind than that's fraud. And so we're really committed to ensuring our program is meets full integrity and national focus on fraud and program integrity. There's a lot of need for us to ensure that we continue to uphold those standards we already have in our program here. So want to make sure, of course, it's a voluntary process. No one is required to, but I want to make sure that she has all the information she needs. And it sounds like there may be some confusion on how this information is used. And so would love to get her that information on how she can make whatever information she uses. Is that helpful context?
It is, absolutely. Thank you, Director Jensen. I think this prompts me to maybe add to our potential agenda item for DSS. There's a little bit of I'm sorry to interject this now, but there's another sort of privacy concern in there. I'm not sure if this is only for Katie Beckett eligibility action families or if this is across the board, but the redetermination paperwork is to be emailed. And there's multiple, I go through this myself with my daughter, multiple private documents, all of our taxes and bills from our home and everything else. And the instruction is to just email it, to Craig Institutional, in multiple emails if the attachments are too big. And there's, I'm not the only one that feels it feels uncomfortable when you're sending all of this very personal information out there. So I do want to put a note on that with DSS. And thank you for addressing that on AB 315. I will speak with that provider and get in contact to verify the secure network.
Absolutely.
And that's a portal, is that through a portal? Okay, okay.
Yep. And the intention is just to be able to match up the person's information on their driver's license with a live image scan to ensure that it's the same person that's applying. There's also been instances where folks have applied to be a Medicaid provider without the physician or clinician that was with under their name, and that's really the intention, is to ensure that everyone going through the process is aware and is part of it, which for the majority of our requirements is not at all an issue, but again, we just have to ensure that we're meeting these, integrity requirements. And everyone is aware of what's happening. So yeah, happy to answer questions and get information on the data security. And thank you for raising the Katie Beckett piece. Would love to discuss that in our next meeting. And also I know we have a Katie Beckett conversation coming up. So I'll do some research on my end to think through if there are other options we can work on with DSS relating to like a secure kind of folder portal or some other way that information can be shared. Because I appreciate, especially right now, any sort of information security is crucial, and we want to make sure everyone feels comfortable sharing what can be very personal information.
Thank you.
I have a question.
Please. Yeah.
Azraella, Vice Chair, I have a question regarding the Senate Bill 138. Member services of Medicaid include a very large population of pregnant women. And it says it requires hospitals to provide birthing services to enroll as a qualified provider to decide if a pregnant individual can receive Medicaid. And I was wondering what those services look like and how can we make it like an easier transition to get our pregnant women in the state of Nevada those services and care.
A great question, Azraella. And something that's really important, the top of mind focus for us. Maternal health is one of our biggest quality priorities across all of the health authority. Nevada is 48th in the country, I think, right now in terms of maternal health outcomes, which is acceptable. And so we're really committed to finding ways to change what we have been doing because it's clearly not working, right? So there's a lot of work underway on our end across the way we pay for maternal services, adding new services. There's a whole range. Actually, I think we can always bring it as a topic here if you want to go into that. We can also share and follow up. There was a legislative committee hearing on this very topic about all the state work to address maternity care. And that happened during our snow day a week and a half ago. It was an interim health and human services committee on maternal health. So we can share those materials if you're interested in taking them as well. But this bill in particular is actually about not just like the services that folks are eligible, but to say when a baby is born and baby NICU services, that can often change their Medicaid eligibility. So if mom is not eligible for Medicaid and baby typically wouldn't be, but because they're in the NICU, they may actually meet disability kind of definitions that would allow them to access Medicaid, especially in a really stressful and busy time for a family. They may not know that. And so this bill tells hospitals, you have to notify parent that their baby may be eligible for Medicaid and how to go through the process to get both preliminary eligibility, what we call presumptive eligibility, and also long-term eligibility for Medicaid, because that can really take a burden, a financial burden off of families if their baby can be covered. So that's the focus there. And we're again happy to talk about kind of what that presumptive eligibility process looks like, but it's essentially just a different front door to the same Medicaid program. So anything that we cover right now would be covered. Does that help answer your question?
Is it temporary for if while the baby's in the NICU, they have presumptive eligibility? Is that what it's kind of focused or geared towards?
So presumptive eligibility is to help get access to Medicaid faster.
Yeah.
And then you go through the kind of permanent eligibility process as you normally would while that's happening. But it wouldn't necessarily be specific to the NICU service. So if they're determined to be eligible for Medicaid for that next year, then they would receive coverage for that full year, regardless of whether that's spent in the NICU, once they discharge, et cetera. So yeah, our presumptive eligibility process is something that we're awaiting, as you can see, approval from the federal government on this piece. So I'm hopeful by the next time we'll have that, we can talk about it. But goal is really to say, any opportunity we have to get folks covered, we want to do it because it helps them get access to the healthcare they need and to lower any amount of money they have to spend on it. That just helps make sure people understand their full options.
And to follow up with that, you noted that Nevada is 48th out of all of states on maternal health. What are some proactive policy making that we're using to address that issue?
Great question. So that's part of what we're looking at with our budget bill right now, actually. What are the things that we can do? So what we can share with you is I actually presented at that legislative committee on kind of the policy changes that states have done across the country that have been positive, and which ones has Nevada done so far, and which ones have we not yet done. So some of the ones we haven't done yet are covering services like home visiting, where a nurse can go to a mom and a mom's house to be able to provide prenatal and postpartum care for them, so you don't have to go into a clinic for appointments as frequently. Other things include establishing more like committees or kind of statewide collaborative processes to review data and to make sure we're acting kind of in lockstep across all of our state agencies to respond to this. It's called a perinatal quality collaborative as a term for that. That was something that folks were advocating for in the legislative committee. As a health insurance payer, Medicaid has a lot of power in how we decide to pay things. So something that we're looking at that I shared with the legislative committee is we're looking at finding different ways to pay hospitals and also outpatient clinics that are delivering prenatal and postpartum care. We can see in our data just around half of moms are getting any postpartum appointments in the 3 months after they get birth.
It's really sad.
Which is not what it should be. And so we need to find a different way to pay for that. That will hopefully incentivize more business. And our managed care organizations have done a lot of interesting pilots to figure out like, why is that rate so low and what can we do? 2 of our MCOs last year did a program with a couple of our hospitals where they made these really cool appointment reminder cards that had kind of a checklist of your symptoms that you should monitor for after you've given birth. If you're feeling any of these, here's who you call. Here's the date of your next appointment. Come in no matter what. Call us if you need a ride. Call us if you need support. Just trying to have that magnet be on my fridge or somewhere for them to really ensure they have something. So it doesn't always look like really complicated solutions. It's usually just the basics and the fundamentals that we need to make sure are being done everywhere with every birth that's happening. So definitely a ton there. I would love to talk about that at future meetings because it's something near and dear to my heart, and I know that passion probably of almost all the members here on this call. We've all had friends and loved ones go through this process, and we've all been babies. So we believe that this is really important, and we want to make sure that we're finding ways to move forward.
And to follow up, thank you so much for clarifying that. What about addressing our exceptions of maternal care? Moms who are in that window, and I know with current country climate, abortion is a big no-no on a lot of legislation right now. And I'm wondering where Nevada is standing on that. And also to follow up with that, with mothers who are pregnant, newly pregnant, and dealing with transitional housing or homelessness, how we're addressing their concerns and getting them to their appointments, and also whether or not they want to continue with their pregnancy and if it's safe or not. And also for pregnancies that are high risk, what are we doing to address additional care?
Great questions. We could spend an hour talking about all this, so I'm really glad you're raising it. I think on what I hear you first discussing is kind of what's called high-risk pregnancies, and I don't always love that term. It doesn't feel good to be called high-risk, but I think we can all appreciate there's some circumstances in which someone can be pregnant, and there's just a lot more complexity to their medical condition, to the social conditions that they're navigating. And so there's a lot of need that we have to be able to support folks exactly where they are, right? How do we meet people where they are and give them the support they need? Each of our MCOs have what's called a high-risk maternity care management program, which is really focused on providing exactly that. The medical services, the social services, things like payments for nutrition, things like housing deposits, whatever folks need to be able to remain in a healthy and safe place to be able to care for their family. So that's something that I know Managed Care Partners are really passionate about and would love to share more about if you're interested. To your specific question about abortion coverage, I won't speak to the broader Nevada landscape because there's a lot of legal complexities to this that change regularly. So it'd be helpful to do a follow-up if we can. But I think fundamentally for the Medicaid rules, there's a federal law that says that no federal money can be used to cover abortion services. And so Nevada Medicaid covers based on the state law requiring it, covers a very narrow set of those types of procedures that are medically necessary due to conditions of sexual violence or medical need. Those are not funded at all with federal dollars. Those are state only, and that's again because of that state law. So if it's helpful to get any background on the state laws regarding this from our kind of Attorney General's team and team there, we'd be happy to bring that to the presentation too.
Yes, I would that.
Okay, yeah, absolutely. We can take that back. I think the overall maternal health presentation would be excellent to kind of review what we cover and how and get feedback on how we can do it better. And Kehlani, I know you're on the phone here, and as a provider within the maternal health space as a doula, I always really appreciate your feedback on this and ways we can better serve moms across our state. So would love to have that conversation.
And just to conclude this conversation, are there alternatives for medically necessary abortions? Are there like interventions to help moms go through adoption services instead? Like, are there options?
Yeah, so within the Medicaid program itself, I don't know that there's anything that's currently funded for that. I think that would need to be a state law that would explore what that looks like. I know that there's a lot of kind of nonprofits and other community providers that help moms navigate in our community. So I don't unfortunately have a lot of detail on what that looks like right now. And it's probably going to depend where folks live across our state. But as a Medicaid benefit, that's not something I'm aware that is currently being.
Okay, thank you.
Yeah.
Yeah, so we do, Kehlani Queen for the record, we do have a lot of nonprofits in Nevada that do help with getting the babies into foster programs and adoption. However, a lot of those are pretty full. There is a need right now for foster parents. So she asked some really great questions. Thank you for asking a lot of those questions. I do have a few more things that I'll say about maternal health, but I'll probably mention those things in the Medicaid Advisory Board. But you did have a lot of great points.
Thank you.
Thanks, Kehlani. I look forward to your input and thanks for adding that color and stuff.
Pause for a few brief seconds just to let any other members online come off mute. Ask any questions you may have, make any comments. Okay, hearing no questions or see any questions in the chat, I'll just hand over back to our chairs.
This is Azraella, bringing attention agenda number 9. It will be a discussion on the statewide managed care. I will introduce the statewide managed care. This is an opportunity for members to share their experiences and observations regarding the implementation process so far. And feedback can include what is working well, any challenges or barriers encountered, and any suggestions for improvement or areas where additional support is needed.
Any members online that would like to offer any feedback on their experiences with the statewide managed care transition as it has started as of February 1st, 2026. Members online.
I know many of our members here, represented here, live in our urban population, so I imagine they may not have felt like as many changes, but as always, we welcome any questions and feedback that you guys have on any of the changes within the managed care program. As I mentioned, there's a big range, so we'd love your feedback, and this is going to remain a top priority for us throughout the year and years to come. Just because it's live now doesn't mean we stop thinking about it. We continue to monitor the way that it's going, work with our health plans to ensure they're meeting all of our requirements. So as always, we welcome your questions and feedback.
This is Kaylani Queen for the record. I think the only thing I have as far as myself receiving Medicaid is I did switch to a new plan this year, and I had to do the health risk screening to receive a few of the benefits that I signed up for. And when I did my health risk screening, it took a while to get approved. That process is pretty long as far as the approval. And when I called back a few weeks later to get another benefit, they didn't have my health risk screening on file. So I'm not sure if there was some sort of issues with them not saving it, or if I have to complete health risk screenings every time. But that was a little bit of a pain not having that on file, because it does take time to go through that process and to get approved. So that was really my main concern so far.
Yeah, thanks for sharing that, Kehlani. I'm sorry to hear that with your experience. That sounds super frustrating to have to resubmit a form, and that's definitely not any of our goals, to have to redo things over and over. So if you want to shoot us any info over email after this meeting with kind of info on those benefits, what your new plan, and kind of what types of what the timeline was there, we can review that case with that team and see if we can figure out where in the process things may have gotten dropped or how we can improve that moving forward. So definitely don't need to share any of those details in this forum, but would love to follow up with you after, just to make sure that we can follow up on how to make this better moving forward. So I really appreciate you sharing that, and would love, if you're willing to spend some time to work through it, we'd love to find ways to make that process better and faster.
Okay, awesome. Thank you so much.
Yeah, thank you.
Azra Ella for the record. So my two sons were previously Medicaid recipients. However, with the new system going over on January 1st, I spoke with Jonathan about this. The only concern I had was that I didn't actually sign up for Medicaid. I was automatically enrolled into it. And I'm wondering if there was a big gap of people who didn't apply for Medicaid that got automatic eligibility.
Thanks for reading. So you're saying you were in the Medicaid fee-for-service program and then you were automatically enrolled in the managed care program, or you weren't in Medicaid at all and then?
I wasn't in Medicaid. My two sons were not in the Medicaid program at all, and we didn't renew the Medicaid every 6 months like imposed. And then so there was like a 6-month gap where we didn't have Medicaid or we didn't apply for it at all, but we still got auto enrolled into this year's system.
Interesting. Okay, I would love to follow up. We can use maybe some information to track this down and kind of trace the steps in our system. The only folks that are enrolled in our program are people that our colleagues at DSS determined to be eligible for Medicaid. So,
and that's what Jonathan had gone over with me.
Cool. Yeah. So the change from fee-for-service to managed care just changes, like, again, the name on the insurance card, right? Like it changes who's paying for it, but it doesn't change who's eligible for Medicaid in general. So I'd love to go through that example, and I can follow up with to get those details, because I'd be curious kind of how
that happened.
Yeah. But I don't anticipate that there were any changes. Like you would only be part of the program if you meet the Medicaid eligibility requirements as determined by DSS. So that would be separate than the statewide managed care.
And it was automatic even if you didn't apply to Medicaid?
It shouldn't be. That's what surprised me.
Okay.
So there are always some complexities, right, where maybe there was that pause where they were researching information, or it may not have been a full disenrollment when there was a pause in services. So that's why we should look into it.
Okay.
Because there could be some complexity there. I'm grateful to our team, our Medicaid eligibility policy experts. I think my colleague Sonia is on the call. It's incredibly complicated how it works. And so we'd love to get into the details with that. But for everyone's benefit, our change with the managed care program doesn't change the kind of criteria of who's eligible for Medicaid. It just changes who's paying for it once you're. So it sounds like maybe those two things happened at the same time. So we should kind of go ahead and do some fact finding on how that happened. But
Yeah,
I think
it affected not only me, but others. And we were a part of the expansion of Medicaid.
Yeah.
So that was the 750,000 people. No, those are without children, but
Yeah, around 200,000. Yeah.
200 people, 200,000 people, yeah. So that could have affected those people. I'm not sure, but I just wanted to put that as a concern.
Thank you. Thanks for letting me know. And yeah, we'll take a look at if anyone else has questions about Medicaid eligibility or your particular situation. I appreciate it. It's a lot of complicated things to wade through, and our team is happy to help sort things out. So don't hesitate to reach out to us.
Okay, do we have any other comments, questions on this section here? If not, then would love to move on to our next agenda item, which is a very important discussion of our back work plan. Y'all should have a copy of that within the materials that were emailed out. As here in person, we've also got a hard copy. And if I can please direct y'all to that document. The back work plan is intended to inform the MAC work plan in a sense. So we want to make sure we have continuity there. And I want to I'll give a moment for folks to look through that work plan, just a couple, 1 minute maybe. Okay. Grace Larkin for the record here. So as I look at the work plan, it seems to me, I kind of view the goal, top goal there. Really, this is in that educating, public awareness piece, educating on the programs, services, benefits that are available to make sure we are increasing that awareness as well as the accompanying educational materials and the strategies we want to use to reach the public most effectively and reach beneficiaries most effectively. To be sure that the services that we do have within Nevada Medicaid are being utilized. The second piece on bringing awareness to upcoming changes regarding the implementation of HR 1. On that, I wanted to, I guess, inquire after our discussion today, are we specifically looking at that expansion population piece, the eligibility requirements that are to be coming up that include for adults without children? and the community engagement piece. Is that what we're talking about in there, in the work volunteer, what exactly on HR1 are we hoping to, review materials on
Yeah.
and strategies?
So I think, I view this kind of education piece, it's kind of a twofold strategy. One is our general strategy on what are we communicating to anyone who's part of a Medicaid program, and then how do we have more targeted communications to folks where we need information from them or things are changing about their eligibility program. So for the HR1 piece in particular, the targeted communication, I think there's value in communicating broadly about these changes. I think there's a lot of information in the news on this, and I want folks in Nevada to really know what's changing and how does it affect them, or hopefully not affect them for a lot of folks who we want to be reassured by that. For people whose Medicaid eligibility is impacted, or there are new rules that change the way that they provide information, that would be our targeted communication. So that would be that adult expansion group. And it would be things like emails and text messages and social media information, physical mailers, posters, right? And a whole suite of materials to say, hey, we may need more information from you to ensure that you are still eligible for Medicaid. Here's a website where you go to for more information. Here's the number you call. Here's where you can go in person, right? Giving folks all of the levers that they are available to be able to provide that info. So that's what I'm kind of thinking on that piece is both overall communications, broader than HR1 for everyone, and then for the more kind of specific messages we need to get across. How do we do that really well? Does that help answer your question, or is that kind of how you're thinking about it too? Because I welcome ideas from others how we can do this best.
Yes, thank you, Director Jensen. That does answer my question. We've got our overall communications, and then the more targeted communication. And it looks like in June, we will be looking at some of that marketing material.
If so.
Yeah. That's the things we have planned for our lesson.
And would that be the point also where we would talk about some of these strategies as far as ways to reach out via text and these other strategies? That would be in our June meeting.
Yeah, and does that sound, I guess, timeline wise, June to kind of discuss those things? Will we have some materials already created, right?
Well, yes, we're going to begin reaching out to folks late summer. And so June would be a good time to get feedback on the messaging.
Okay.
We'll also have the broader marketing materials from our MCOs for the upcoming plan period that folks can review as well. So I think having a kind of communications focused discussion in our June meeting would be well timed.
For the purposes of the work plan, adding for the June meeting, to add an agenda item to get some feedback on HR1 requirements, messaging for the HR1 requirements implementation. That's my boundary.
Yeah, it looks like because it looks like it's specified in the goal, what were you saying? But in the actual meeting schedule, when it lists our June meeting, it just says review of marketing materials, which
If we can
kind of
add it.
encompasses that, but I think if you wanted to add that specific on there, just communication.
HR1 feedback.
Yeah.
Yeah,
Yeah, or just that kind of communication piece overall.
because we touched base on the feedback during this meeting, and if we can just continue that communication.
And just to clarify, the review of marketing materials on the agenda focus for June, it is the Managed Care organization's marketing materials. So that's we can add that in just to make it clear.
Okay.
MCO.
So we may be reviewing the MCO marketing materials as well as the,
Marketing materials for HR.
yeah. Okay, this sounds good. And just to confirm on that expansion population piece, the timelines, Dr. Jensen,
No, thank you. Director.
Director Jensen mentioned there's a policy workshop on the requirements coming up March 21. So I'd love if we could get that forwarded out to us, at least the dates.
And March 21st is a Saturday, so I apologize, that's on me for telling you the wrong date.
Okay, so
I'll take a look and find the time that is held, but we will definitely, we'll send you the full information all about your website, and we'll make sure that's passed along to all members and anyone who's here. Yeah.
okay, and those requirements, I believe you said February 21st, 2027? Is that the when?
Yeah, so community engagement requirements, all states have to be effective January 1st, 2027, so the beginning of next year. And then the other eligibility provisions, there's a bunch of different changes. Some go into effect starting this October, related to immigration status. Others will go into effect throughout 2027. So we can bring you kind of a summary of what that looks like, but bottom line is this fall is the changes. We'll start with the biggest one, community engagement is.
Does anybody have more feedback on that piece, this communication, educating, and awareness piece of that goal?
Hi, Azraella speaking, Vice Chair. So in June, I noticed that one of our goals for evaluation and reporting is to have a percentage of recipients' level of knowledge on Medicaid services, benefits, and programs. I know that is pretty broad, but if we could have that on our agenda for June on what that could look like, because I believe it's very important for benefactors or beneficiaries to understand what services they're provided and what that looks like for them and how they can have like maybe a flyer or something sent out to them so that they can have access to that information, or what either via email, all the various tools that Medicaid provides our beneficiaries. I think it would be very helpful.
Yeah, absolutely. We can definitely do that. Our kind of services that are covered, I think honestly, this is where MCOs probably do better than the state does. They have really excellent memory handbooks that include details on.
They're very long.
That's fair. Very long. Yeah, and that's the hard part. Right? Like, we cover so many things. So how do we find a way to communicate it both with detail, but also in summary? So maybe we can have our MCO staff come and join us, and they can hear any feedback you all have on those materials. And then on the state side as well, I think we actually could probably do better on that front too. And so let's do that.
Yeah, I was just suggesting instead of a manual, like have a brief flyer of like, hey, you're in this MCO. This is what you have access to. Because I know in our last meeting, all the MCOs did such a wonderful presentation on all the benefits available, but not necessarily those Medicaid beneficiaries would have access to that.
Totally. How do we get a one-stop shop with one quick place where folks can see?
Yeah, if they could just mail a flyer out to beneficiaries, that would be wonderful.
It's a great suggestion. So I think Patty from our managed care team is on right now. So maybe Patty, you can take that back. That's a suggestion. The team meets regularly. Our managed care team meets regularly with each of our MCOs for that suggestion to them. If they don't already have those types of one-pagers, to create them, because that could be a really good way to just communicate with folks and helps those. Can be pretty complicated. It's hard to wade through those number of them. For my health food provider, it's hard too. So let's find better ways to make that more readable.
Yeah.
Yep. Good suggestion.
Even just like reminder text, like, hey, you're a part of this MCO and you might be eligible for a $28 gift card for et cetera, because I know a lot of the MCO's presentations had mentioned that in our last meeting.
So with that, is there any language you'd like to add to the work?
I just saw that in our evaluation and reporting, there was a goal to educate Medicaid recipients and others on the Medicaid programs and services. And I highlighted that the percentage of recipients' level of knowledge could be limited due to those manuals being very thick. If we could just have not necessarily feedback, but a template of a flyer or some type of correspondence for our beneficiaries. I think that would be very helpful.
I also think that to help us evaluate this piece, I think something that we suggested in our plan, and like I said, these were just suggestions that we put into kind of based off of the conversations we've had in the past. I think that this is maybe something we can add what you just said in the key activities and deliverables. Does that sound?
Yes, please. Thank you.
And then probably another piece on how we're going to evaluate that. I think we do have it here. We have as an activity, the beneficiary satisfaction survey.
I see
Where
that.
we can create a survey to distribute to members. I can't remember if that was for members or also to the general public to kind of have that baseline of where the knowledge on services and benefits kind of stand, and then doing that survey maybe a year later to see if it's improved.
If we can have it as a public option, I think that would be very useful as well.
I'm really glad that you brought this up. This actually was the most interesting piece here to me. I think there's so much that we can learn and get out of this, you know, for moving forward, is that beneficiary satisfaction survey. So I definitely see the benefit in having one for general public, but I think that one that is specifically to, you know, members and beneficiaries that really could give us insight on where folks are getting, you know, hung up, where things are going well. That's really nice to know. But, you know, very specifically procedural and you know, different facets and even if there are aware of services. But I'm very curious, you know, what that survey is going to look like. Who is putting that together? You know, how can we get into it as it's drafted? How do we plan on getting that out? Are there incentives to filling it out? And then once we have that information, you know, having some expert input on interpreting it. Because I think that can be a really big piece too. I mean, when I've reviewed different survey data, it can get, you know, tricky to really have a really good evaluation of it. So those are some of my questions. I'm sorry I threw them all out there, but you know, what is that survey going to look like? Who's going to be building it? Can we have input? How's it going to get out there? And then how will it be evaluated and interpreted?
Okay, those are all really, really great questions. I think that, so as this is an activity only back work plan, my understanding is that this would be kind of a survey that would be created by the members of the back.
Great.
We will do the work as far as putting it together, but for questions and items to be put on that survey, I think that would be up to you all.
So question on that, if we are unable to meet outside of these, of our actual quarterly meetings, it makes it a little bit difficult to work on it together. We could have a strategy in, I guess, via email conversation of give your input on what we would like, and we can gather those things and then have it on an agenda that we look at everybody's. Does that make sense?
Yeah, we could do it that way as well, if that's how you would.
Or if there could be a work group, is the.
I'm
Yeah.
sorry, so sorry to interject.
Yeah.
We have open meeting law, so
Yeah.
we can't do communications via email
Yeah.
on these types of things. It has to be in an open public meeting.
Mhm.
So in actually building that survey, I mean, we
would
can,
have
we
to do it
can,
here.
we can comment, we can all know that it's on our agenda and have our notes that we have taken and that are ready to discuss. But I guess we're going to have a really, I think, active agenda item to really work to try to finalize it. I don't know if June is sounds like there's already a lot happening at the June meeting. And then also we have we have some term turnovers.
Right.
Yeah.
Which I was actually, I have a 2-year appointment, so I just recently found out from y'all that there are the 1-year appointments, which is tough with quarterly meetings. It's really too bad that we have to.
Yeah, so maybe instead, I think that, yeah, so I think instead maybe of doing this, because this seems like it could be a maybe not as feasible, maybe it's just giving a recommendation in the meeting on maybe the state Medicaid agency doing something like this or an initiative, and then we can take that back and see how we can implement that. And I'd like to know if there's any feedback you have on that or any suggestions.
Yeah. No, I think you're spot on. I think it's always, quarterly meetings aren't always frequent enough to move forward with the work, but we also want to make sure that you're able to give really constructive feedback on what that looks like. So I'm open to what your guys' suggestions are. I think if it's easiest to kind of give a recommendation for us to develop something and bring it back to the group for review, I think that's absolutely something that we can work on, and that they will have a starting place to react to, and we can maybe move through that more quickly. Or if it's, will we focus on other things in June and we want to just make a recommendation in June to the state to create a survey for future kind of back groups to review, we can do that as well. So that's not a particularly helpful answer to say that there's a range, but I think that's the intention, is to say, like, you all can really guide us in what this can look like. We can also give some more context, maybe in a future meeting, on all the different surveys that already happen, right? So there's a lot of work the federal government holds us to do kind of random kind of member group surveys and feedback that we're looking to develop. And so I want to make sure that we're kind of aligned in all the different ways it's currently happening, and you all can recommend to us where there's value in adding further options. So what are your thoughts there?
I think it would be, I think in June, I would like to have an agenda item on this, the survey, and it would be great if at that meeting we were able to have access to some of the current surveys that are being made. And I think we could, from that, probably I think we'd be able to sift through that and see what resonates and see going forward on it. But let's even, I think before moving forward, asking like internal Medicaid to work on something, I would like to well, let me ask the committee, what do y'all feel? Would you prefer that we request that Medicaid internally move forward with a draft for us to
Amend?
amend or review
Sorry,
of the survey?
I think, so I kind of want to piggyback off of what Erin suggested. Maybe something that we can do as an activity is we bring a presentation of what we currently have as far as surveys go, because I know we do have some surveys that we have available to the public and to members. Bring that to the next meeting, and as a deliverable, give feedback on what those, on any suggestions on what to add to those surveys. I feel like that might be a little bit more feasible.
Yeah.
What are your advice? So we can start like that, and then if the recommendation is we want a new or separate survey, or we amend existing ones, we can have that, tee that up in preparation for, will that be September?
Yeah.
September meeting. Yeah.
That was my inclination. I wanted to see if anybody had other thoughts on it, but I think that would work. And I hate to hang it up, to draw it out longer than necessary. I think there's probably enough out there already. And if we just can get it moving, because I do think it's going to be really valuable for us moving forward as a reference point.
And to voice on that subject, is there a current survey after prospective beneficiaries complete the Medicaid application at DSS?
Good question. I'm not sure about that.
I think-
I imagine that there may be some sort of surveys, but I don't know what that looks like. So we can tee that up if the request of members is to have the conversation about the eligibility enrollment process.
Yeah.
With our DSS colleagues as well as our policy team that leads that, we can tee up that question for discussion.
I think that's really important to follow up after a prospective member has filled out an application, what their experience was and get feedback from that. And also after they have the acceptance letter, maybe follow up with a survey to see where their knowledge is lacking or could be improved with that survey.
I love that.
So going to the language that's in the work plan. Just want to confirm with the members as far as, again, the activity, perhaps that's instead, reviewing current Medicaid beneficiary satisfaction surveys that we have available.
Mhm.
And then providing some recommendations on how we can better capture information in those surveys. Possibly.
Yeah, I think we probably also need to address how those are going to be put out there. How are we going to get a full snapshot back and as many as possible? And then also that maybe that evaluation piece afterwards, how to interpret, evaluate that information.
That's why I thought of having a survey completed by the prospective Medicaid applicants at DSS, because then that could be more of a, it would be available to them and then they can just put it in a Dropbox, because they fill it out there after they apply or get their benefits. Sometimes it happens where the member has to come in for a case review or a case setting situation. So they would have to go in person anyways, and then follow up with that survey of how their experience with Medicaid was. And then once they have those benefits available, if they had any questions, they can also put those concerns in that survey, follow-up survey. And that's what my idea of the satisfaction survey looks like. Does that make sense?
Yep, it does. Yeah, and I think what that's also making me now, just taking a quick note here is, as we build a new online platform, Medicaid Express, we want to do the same thing. Like we build then a survey at the end of that experience, even if folks are in person to get feedback on that. So I'll confirm, I imagine that's still on the list or that's already on the list for our team, but we'll also take that back. Because I think at every interaction that either the state or our CEOs have with folks, we should offer the opportunity for folks to provide feedback if they so choose.
Yeah.
And then be really thoughtful and review it.
Okay.
Just want to go over what I added to the work plan and instead based off of what I'm hearing. As far as the activity review beneficiary satisfaction surveys, Medicaid has available. And then as far as the deliverable, provide recommendations on current survey language, formatting and distribution methods.
I would recommend we include our managed care partners in that too, because they're also doing a lot of member satisfaction survey work, and so I want to make sure that's.
And just lastly, the method of evaluation or review of the results. Because that's gonna be a lot to collate. Who's doing that and how is it presented to us? Just looking at that in advance.
Yeah, that's great. All the members are reviewing it.
Right.
So whole process.
Evaluation of surveys.
Yes. Okay, Grace Larkins, for the record, do we have any other feedback on the back work plan at this time? Okay, and because we have some changes that will be coming through on this, I think we hold off on the motion to approve, or
Make a motion, if anyone would like to make a motion to approve with the changes, you can, otherwise you can also wait for all meeting if you would like to wait to incorporate any other changes later.
So I will officially, let's move on to agenda item 11, approve work plan. I feel that with the discussed changes, I would anybody like to make a motion to approve with changes that we've discussed? The back work plan?
Just this is Gabe Lyther with the Attorney General's office. It is a good idea since it has been agendized as an action item, and you guys have discussed some potential changes to go ahead and just have a formal motion and a vote on that.
Thank you, Gabe. I'm happy to make a motion to approve and move to a roll call vote on that. Do we have a second?
I second that. Azraella seconds that.
Do a roll call vote, if that's.
Approved?
Bill? You still online, Bill?
Sorry, yeah, could you repeat that? Sorry.
We're just going through roll call to, for a motion to approve the, back work plan.
I would be okay with it.
Okay, great, thank you.
Thanks.
Azarella,
I approve.
Jessica,
I approve.
Kaylani,
I approve.
I'll go ahead and call out Brooke as well. I'm not too sure if she was able to join later during the meeting, but I'll call out Brooke Blanco. And then Grace.
Yes. I approve. And with that, the motion is approved to approve the back work plan with changes as discussed.
And Azraella, Vice Chair, I would like to address agenda item 12, public comments. If you would like to make a public comment, please raise your hand or type public comment in the chat or the last 4 digits of your phone number.
Sorry, I think we're.
Oh, okay, sorry.
Oh,
We did.
all right, it's not reflected on this material here, so. Agenda item 12, we'd like to move on to agenda item 12. This is a roundtable discussion. We have discussed potential agenda items for the next meeting. To look back on those, those related to the survey as we just discussed, which is going into the work plan. We also have mentioned communication, I think, all around communication, and also the targeted messaging that related to HR1.
And I know we'd also talked about Medicaid eligibility processes as well, so I think those are actually fairly aligned, but I know that's a lot of topics. So, and then Azraella, I know you also mentioned maternal health, and I know Kaylani, that's also, you mentioned interest in broader discussion on that. So, would love to, I don't know how we want to think through prioritizing those, but we may need to split some between June and September. I think those are the 4 that I've heard today as kind of key areas.
Yeah, we also discussed that, the eligibility of the DSS piece, yes. Yep.
Also discussed with the maternal health. But if the others are priority, maybe we can decide in a future meeting.
At that future meeting, and Director Jensen, you had mentioned that you had given a presentation around some of the national MCH, maternal child health. what I'm referencing there, some of the national approaches that have been successful, including some that Nevada has been looking at and some that could be for consideration. I think that would be a really valuable input.
Yeah, we would be happy to bring those items maybe in September. Yeah, I think that'd be great.
In previous public hearing workshops, I believe that diabetes supplement services were added to legislation.
Related to coverage of diabetes, like pharmacy prescription drug related.
Mhm.
Yeah. So maybe some detail around our policy regarding diabetes care services.
Yeah, because of the changes that were implemented.
Yeah, so I think on the Medicaid side, we're happy to follow up with some detail there. I think it expanded a little bit of coverage of certain components of that care. So if that's of interest, we're happy to bring that.
And what's the demographics for our diabetes population? Is it pretty large?
Great question. I don't know. And I do know diabetes remains in the top 3 conditions that our patients covered at Medicaid are experiencing. So we can maybe bring our population health experts and data team to present a little bit more about chronic conditions if that's something.
Yeah, especially if it's a big demographic in our population.
Grace Larkins for the record. We've also discussed some of the prior authorization updates and changes that maybe I think have partly already been put in place. It would be, I would love to see a little bit more clarification on where Nevada is in the implementation of those.
That's a great suggestion. There's a lot of reporting that we're ultimately trying to get to that, and so I think we should bring that to an upcoming session, whether it's September or December, but I think it's on the agenda. Bring it across state's performance as well as to PA responsiveness and how quickly this get into.
Yeah, prior authorization is important for providers. I believe we also discussed the MCOs possibly making a flyer to be delivered to our beneficiaries, maybe a single page, as you mentioned, of all the potential services that are available for our beneficiaries. And that's important to summarize for our MAC meeting.
Yeah, I think that one would fall well within the communications kind of strategy that the episodes will be preparing for the June meeting already. So yeah, we can take that back and hopefully we can stick that in.
Perfect, thank you.
I'd also like to pause for a brief moment for a lot of those online. We want to come off mute and possibly suggest any agenda items for the next meeting or anything else that they might want to make comment on.
Yeah, actually, sorry guys, I was just trying to think of how to word this. Bill Sims for the record. I just wanted to ask, maybe this wouldn't be the place for it, but is it possibly something that might have to be talked about with the recent announcement from Dr. Oz in regards to the orthopedic and braces issue with not wanting to or putting a pause on paying out new contractors over the next 6 months? Like, is that something, because I looked into it and I know like directly Medicaid patients wouldn't necessarily have to worry about it, but given we do live in Nevada, a lot of Nevada's rural, so I worry about like if people close down who are Medicaid patients, how are they going to get things taken care of if they're on Medicaid?
transportation.
Yeah, thank you, Bill. I really appreciate that. And you're right, there's been a lot of national news on a lot of different topics. So you're pointing out one that came, I think it was midweek last week, which feels like old news in the Medicaid policy world, but it's a really important one. So I'm glad you brought it up. The portion of Dr. Ozz's announcement on that piece is specific to Medicare, actually, and Medicare enrollments for DME providers. But we definitely appreciate, Nevada has our own regulations regarding how DME providers are enrolled. There's no changes that we're held to make to that based on the federal announcement. So I don't know that there will be any particular items to bring for discussion, but if you're hearing concerns related to access to DME, especially in rural areas, would be more than happy to talk through that because I share your concern and focus on making sure people have access to what they need regardless of where they live. So thank you for raising that. And if there's any specific things that we can talk through, I'm happy to do that. For the
Okay.
purposes of the Oz announcement, that one was, it's confusing. And I was also having to read the details there because he talked about a lot of Medicaid things, but then he also talked about Medicare, and that one was specific to Medicare. So on the federal side.
Okay, thank you.
Yeah, thank you. I really appreciate that suggestion.
Okay, do we have it?
Oh, I'm sorry. This is Kaylani Queen for the record. I was also curious as far as people, Medicaid recipients, filing a report on a provider, a Medicaid provider. Is there a way that recipients are able to file reports if they feel that maybe they were neglected or, harmed by a provider? Is there a system that just makes it easier for people to file these reports?
Yeah, thank you, Kelly, for raising that. Yes, that's something that we take very seriously, and I want folks to be really clear where to go to with any concerns. Anyone can always share a complaint with the state or with the managed care organization as an appeal, or what's called a grievance. The other way that you can submit those is through an appeal to the licensing board or whoever oversees that provider, regardless of who's paying the service. And so, but we can actually take back, I don't even know, we can even do it as kind of material that's shared in coordination with an upcoming meeting, but we can provide links to where all those sources are and also make sure that you have those as soon as possible if that's something that you're interested in as well. We definitely want to make sure that process feels clear to folks. So thank you for raising, and I think that's a great item that we can bring some materials related to. And if you all have feedback on how to make that process clearer or easier, we would love to hear it. So thank you for raising a really important topic.
Yeah, no worries. I wasn't sure if people could maybe file reports on like the app or just something that's a little bit easier for people to navigate if they have a complaint or a concern or if they were harmed in any way. I think that's definitely something that needs to be brought to the attention of Medicaid to look into these providers.
Absolutely. That's a great suggestion on the Medicaid app. We can look into that with our team that develops that app. Our team is also, all states are held to create what's called a grievance process. So a new way of receiving complaints. And so we're actually in the process of doing that right now. And so maybe that's something that we can add to our list maybe this fall to bring and give a broader presentation on the grievance process. That is a little bit broader than what you're mentioning, but I think is really relevant. And I would love feedback on how we're designing it to make sure it really addresses, the opportunities you see.
Yeah, I think it would even be maybe helpful to do some sort of follow-up after somebody goes to a visit. Of course, if you go to a wellness care visit, you typically are able to rate the provider through their personal systems. But if Medicaid can also do some sort of survey after we go to our visits, that could be really helpful on ways that changes could be made moving forward.
Yeah, no, I love that suggestion. You're right. I think that also ties in well with our survey, satisfaction survey agenda item in general about at what time is it most helpful to get feedback. And you're right, that maybe doing it right after an appointment or any other service may be a really good time to do it. So let's kind of tag that on to our agenda item related to surveying. Hearing what you're saying, that it's a little bit broader than just a surveying. It's also providing, anyone can raise their hand and give feedback at any time. So I think that would be a good thing to add to that agenda item we have coming in June.
Yes, I agree. I also want to say that it would be important for them to also give feedback on specific hospitals as well. If they've had any issue with providers at the hospitals, it would be important that there is something in place for them to speak on those issues and how they were treated at that specific hospital.
Yeah, absolutely. I appreciate that. And we'll make it clear kind of where, or kind of the range of things that are welcome in terms of feedback there. And then we can also share a little bit more about what our process will be to provide that feedback directly to our providers so we can ensure it's kind of taken seriously and addressed. So if we've raised that, that's another good example of something we want to incorporate in that feedback.
Yes, no worries. Thank you so much.
Yeah, thank you, Taylor.
Okay,
Does Bill have another question? It looks like.
Bill Sams, do you have another question on?
Looks like his hand's raised, but I'm not sure.
Oh, no.
Oh, okay.
Okay,
Oh, I do not. Sorry, Microsoft Teams throws me off, so no, I don't. I'm sorry.
No worries, though. Teams and I have a challenging relationship too sometimes, so you're good.
One question to follow up from our last meeting. I know that we talked about access to care and that MCOs have expanded that access to care and has done a wonderful job, might I add. However, we haven't addressed the transportation barriers yet. And I wanted to possibly discuss that as an open discussion before we conclude this meeting.
As long as we can do that, I'm very open to it and would love feedback. We do have some changes to the way transportation is designed as part of our managed care program as well. And so it's kind of newer how it's being managed. And if you have any suggestions on it, we're actually preparing to procure our broker contract, how the state works with transportation providers. So feedback is well timed. I would love to hear.
From the Reno's perspective, I know that Uber and Lyft kind of co-sponsor some of the transportation allocation costs through the providers of getting them from the hospital and back to their home, especially for elderly care. I'm not sure if that's what you meant by the broker contract or if there's a different one that providers are using through Medicaid. If you could.
Yes.
Insight about that.
Yeah, so good questions. There's a lot of different ways transportation happens. The state has a contract with a broker right now. It's called the Medical Transportation Management, or MTM. And they're responsible for working with local providers to ensure that folks have access to care. In our rural communities, Care Source and Silver Summit use a broker called Safe Ride, and they do the same thing. They work to identify providers and they manage the business. So if anyone needs transportation, they call wherever they live, one of those two brokers, and that broker helps manage, they figure out who in their area can provide that ride and how to get that scheduled. So your question about Uber and Lyft is a good one. I'm actually not sure right now exactly what the contracting or relationships look like between Uber and Lyft and both MTM and Safe Ride brokers. But you take that back to our team and see if we know more. They are really helped to figuring, they're helped to just make sure people get rides. And so the way they do that, they have some related contracts. So I imagine maybe some partnerships there, but I'm not actually sure. So that's a really good thing for us.
Yeah, thank you.
great. So Jonathan, I believe there's been some questions and comments in the chat that have come up. Would during the roundtable, or any of those to come up, I guess if they're members of the committee, or are some of those mostly going to be for our public comment?
If they're from the public pool, that's what's to the public comment.
Okay. So we have everything in the chat addressed that is from committee members at this time. Does anybody else have thoughts here in person or online on future agenda items? Okay. With that, let's move on to agenda item 12, comment. If you would like to make public comment, please raise your hand or type public comment in the chat. Or the last 4 digits of your phone number and your name will be called on to begin. Please state your first name and last name at the beginning for recording purposes, and you would have 3 minutes to speak.
We have Chair Leah Cartwright. Leah, do you want to come off mute?
Hi, thank you. Good morning. This is Leah Cartwright. And just a quick question back to the beginning of the presentation from Administrator Jensen. It's totally fine if there's no answer to this today, just in thinking about the future legislative sessions and the future Medicaid budget and all of those things. Administrator Jensen, you had mentioned that we have in law the provider payment floor in MCOs is now equivalent to fee-for-service. And I was curious if that applies to future legislative changes in, for example, the 2027 or 2029 session, or if that provider payment floor only applies to the current contract and the current fee-for-service provider payment level. So if there's, a new change passed in 2027, would it take effect under the current MCO contracts, or would it have to wait until the next contracting period? Thank you so much.
Yeah, thank you, Leah. I appreciate the question. And it's a good one. So the provision of our contract applies for the full length of our contract. So from 2026 through the end of 2031. And it applies to our fee-for-service fee schedule during that entire time. So if there's changes to our fee-for-service fee schedule as a result of 2027 or 2029 legislative sessions that go into effect during that contract time period, that provision would apply. I'm sure you can appreciate, as with any policy, there's always some nuances and some exceptions. So there are some areas of our fee schedule where that does not apply as it relates to payments where there's value-based arrangements or other things. But for the most part, that would apply to every component of our fee-for-service fee schedule as that continues to evolve in the years ahead through the full term of the contract period. So in preparation, or as bills come up during session, we evaluate the fiscal impact to our program as both the fee-for-service cost of a rate increase as well as the cost to our managed care capitation rates, because they're held to pay them. That means that it costs more for them to deliver the program, and we have to ensure that's reflected in their rates. So you will see that in any kind of fiscal note related to rate increases, both on the fee-for-service and managed care side. So I hope that's helpful to answer your question, and I appreciate you being here and asking.
Do we have any other public comments?
Seeing no others in the chat, that's right.
I would just like to, this is not hiding for us, for the record, I would just like to add that we will be recruiting for a Beneficiary Advisory Council for new members on this council here pretty soon. If you're interested in applying for a position with the Beneficiary Advisory Council, you can send an email over to community and provider at nbha.nv.gov and include your resume as well as fill out your application, which we will drop in the chat. Yeah, hopefully we can get some new members.
Monica, I see you have your hand raised.
Thank you so much, Jonathan. I just wanted to add on to Nahibi's comment about the recruitment. If you could also explain the consecutive, non-consecutive terms for those who might be interested in the future but are currently still serving.
Correct. So for those members that are currently serving on our Beneficiary Advisory Council and have their term ending here pretty soon in June, I believe. If you would like to serve again on the Beneficiary Advisory Council, you may apply in the future. You just cannot serve a consecutive term on the council. If you have any questions regarding that, please feel free to reach out to myself or Jonathan or our email community and provider at nbha.nv.gov.
Thank you, Nahibi. I also, on that note, for recruiting, we have discussed the need for some representation on the committee from the rural areas. And I think that's something, to my knowledge, right now on the back as well as the MAC, there's not rural members. So I don't know if that is something that we have a way to kind of actively recruit to some of those areas, or maybe even reaching out to some of the individuals who are already active within some of the rural committees that are formed. I'm sure between the Rural Health Transformation project program, as well as I know there's a few. So maybe we could reach out and see if there's if they themselves have any interest or they have some recommendations.
Yeah, it's a great idea, Grace. I think we should absolutely share this with our RHT grant committee for them to kind of share from the communities. There's a lot of community leaders that are part of it. Another idea I had while you were sharing was we have an excellent district office in Elko. And so I'm wondering if maybe we can put up a poster there to advertise this opening as members come in and have questions or maybe needs that maybe one opportunity, and our staff at the Elko office may be able to help us think through other creative ways to recruit in that particular community. But I agree, I'm really committed to hearing more from folks across our whole state, and we want to be thoughtful in how we're recruiting in this way. So I would welcome any ideas from others on how we can best do that moving forward.
Okay. All right. Gonna update my vice chair. We were out. Okay. So we would just. All right, if we have no more public comment at this time, then we can move on to agenda item 13, adjournment. And I will hear at 11:19 a.m. on March 3rd, 2026, adjourn this meeting.
Great. Thank you all for being here and for taking time out of your busy days and lives to be here. I really appreciate it. And it's a lot of conversation. So thank you all again and look forward to seeing you soon. Thank you.
Thank you, everybody.
Thank you.
Appreciate it.
I think we can.
Thank you, guys.
Thanks, Bill.
Thanks for
Yeah, a little bit early too.